Muito bom dia a todos. Muito obrigado ao Daniel e à Rosa por me terem convidado para fazer a introdução do Antons. Deixem-me só dizer uma pequena coisa antes, que eu não resisto, para quem me conhece. Eu acho que estava aqui a pensar, ali sentado em cima, que estas sessões de abertura deviam ter um rapporteur final que pegasse nas coisas importantes que disseram os vários oradores e puxasse isso à pedra. Porque são ditas coisas muito importantes que eu, desculpem-me, já as ouço há muitos anos, ando nisto há muitos anos, e depois, a passagem à prática, continuamos à espera. Nomeadamente, o reconhecimento do papel das organizações não governamentais e das pessoas que vivem com as patologias que estamos a observar no processo de decisão do sistema de saúde. Eu tenho que referir isto porque houve recentemente, a comunidade sofreu de uma enorme frustração pelo papel, ou a decisão final tomada pelo Infarmed, depois de mais de um ano de um processo em que a comunidade participou convicta de que a sua posição era tomada em conta. E com isso garantido, chegou ao fim e foi tudo atirado para o cesto dos papéis. A comunidade desapareceu dos sistemas de avaliação das tecnologias de saúde e foi das frustrações mais recentes e, portanto, eu sempre tiver a oportunidade vou falar dela. Vou remeter-me ao meu papel de moderador. Antons é um medical officer da região da Europa, da Organização Mundial de Saúde. Está sediado em Copenhaga, Dinamarca. É responsável pelas atividades relacionadas com as hepatites virais e presta apoio técnico aos Estados-membros. Tem um curso de medicina na Universidade de Riga, em Látvia, e trabalhou como médico durante vários anos, em que colaborou e esteve envolvido com organizações da sociedade civil, organizações profissionais e outros networks na área do VIH, hepatites virais, prevenção, quer na prevenção, quer na investigação. Tem um Master Degree em Epidemiologia Aplicada do Instituto Nacional de Saúde Pública de Madrid e vai-nos trazer uma apresentação sobre as estratégias globais que foram recentemente adotadas, em maio, da Organização Mundial de Saúde, bem como os action plans para as respostas do setor de saúde na região europeia. Portanto, vai elaborar sobre isso e informar-nos, eventualmente, não sei se vai ter tempo de nos falar ainda das próximas recomendações sobre teste em meios comunitários que a WHO está a preparar e que se pensa sejam emitidas no final deste mês. Portanto, por isso.
Thank you, Pedro, for kind words and the presentation. And I'm very glad to be here and very thankful to Luis and to Daniel for this invitation and the possibility to present the, let's set a global scene. If we talk about a response to HIV, viral hepatitis, and sexually transmitted diseases, and we have to look also from the global perspective to see how also action on the local level is supporting the global goals of eliminations of these major public health threats. And we, WHO, always has promoted and advocated and facilitated collaboration of the civil society, of the community-based organizations within as a key stakeholders in a national response to, particularly to HIV and viral hepatitis. So I'm really glad to be here. So first of all, I will tell shortly about the global strategies that have been adopted just in May this year in Geneva at the World Health Assembly. And then I will tell you about the process of the development of regional action plans for HIV and for viral hepatitis that will implement the global strategies in the WHO European regions, not only in the EU, but also in the Central Asia and Eastern Europe. So now this year could be a historical year if we consider that the world has adopted the 3 global health sector strategies for HIV, viral hepatitis, and STIs, which are aligned with the Sustainable Development Goals, the Agenda for Sustainable Development for 2030 is the United Nations commitment to achieve certain goals, and there is a particular goal 3 which relates to health, and it has targets which calls for elimination of stopping the epidemics of HIV and combating viral hepatitis. That means that the world, on a global level, all the governments have agreed that the action needs to be upscaled to reach those targets. So these 3 strategies, why they are coming together, they have all a common structure. They are all based on the concept of universal health coverage. That means that all people who need services, that they need receive those services without financial hardship, so that everybody should have equal access to needed services. So all these strategies, they are, they're also based on a cascade of services component. They have a vision, they set the global goals and targets, and they are also coming with a costed action. So they're also in the strategy, their estimation of how much it will cost for the world, how much it will cost for the country to combat those diseases, and how much it will save in terms of lives and in terms of the finances as well. So, this presentation of the global strategy, first I'll tell about the introduction, then describe the strategies, and then the next steps for Europe. So these 3 strategies I already mentioned are meant to ensure the health sector implementation of the United Nations Agenda for Sustainable Development. And in terms of HIV, we need to sustain the success we have already reached, but we need to address the unfinished business and a guard against epidemic rebound. So we need to make sure that we are on a right track. For the viral hepatitis, this will be the first global strategy, and the viral hepatitis is a huge problem globally, which has not been addressed appropriately until now. And in terms of STIs, we need to, as also Luis mentioned, that this is a neglected area. We kind of forgot about them, but we need to focus on elimination of syphilis and mother-to-child transmission of HIV. So why now? So as I already mentioned, these 3 areas of disease, they are major public health threats, and the progress has been uneven and inequitable in different parts of the world, in different regions, and even within the regions. Within the European region, we have very diverse success. So we have new opportunities, there are new medicines, there are new technologies and approaches how to address these epidemics. Particularly viral hepatitis have seen a huge progress in the possibilities in terms of new drugs and new diagnostics. So the cost of inaction might be very high if we don't implement those actions, then the cost will be even higher in the future. For HIV, as I already mentioned, this is the contribution to the UNAIDS multi-sectoral strategy, which also aims to end the AIDS epidemic by 2030. So there are 16 million reasons, or to be more precise, 17 million reasons to celebrate. That means that it was estimated that 17 million people are receiving IRT at the end of the 2015. But still, the pace of the epidemic is not close to the end. The service coverage is unequitable, and HIV incidence is increasing in some countries, and regions. And as I mentioned, that with this we actually mean very much the Eastern Europe, particularly Russia and Ukraine. And then interventions are often poorly focused, so there are a lot of action, but those populations who are most in need, they are not reached, they are not addressed properly. And then also we can see on the global level the shifting of donor priorities, and the Global Fund, which has been supporting the countries, low and middle-income countries, that gradually removes its funding. So there will be a process of transition from external to national funding in those countries, which might be very challenging. So, and then to accelerate this access, we need to focus on the fast-track actions, and most importantly, to build sustainability. In terms of viral hepatitis, it has been acknowledged as 7th highest cause of mortality globally, mostly due to chronic hepatitis B and C. And this will be the first global strategy to set the global targets. And it has been estimated that to eliminate viral hepatitis, the 5 key priority intervention needs to be upscaled. And this refers to vaccination for hepatitis B and prevention of mother-to-child transmission, infection, blood, and surgical safety, harm reduction for people who inject drugs, which in terms of prevention of hepatitis C is even more important and needs to be more upscaled, even higher, comparing even to HIV. And then testing and treatment for chronic hepatitis B and C to prevent mortality and also to prevent further transmission. So, so this is the flow chart of showing how the global sustainable development goals are leading through the health sector strategy to the national action plans, which will be implemented on the local levels. So, as we mentioned, the World Health Assembly adopted the global strategies anonymously in May 28th of 2016 in Geneva, and this was a historical and very moving moment. I was streaming online, and there was a lot of emotions among those who were involved in the development of this. So Europe and European region also provided a lot of input in the development of those strategies. There were regional consultations and with the civil society and public online consultation in different languages, including Russian. And in June 2015, we had regional consultations with more than 110 to 20 participants from member states, or from the civil society, and from major partner organization. So there at the regional consultation, participants also indicated the need for development of the regional action plan, which will align to the global strategies, but they also need to adopt them to the European context. So the global strategy, they follow the same structure as already mentioned. They have global vision, goals, and targets. They use the framework of universal health coverage, the continuum of services, or cascade of services, and the public health approach. And they have 5 strategic directions, and 3 of the strategic directions, which are in the middle, are representing the 3 dimensions of the universal health coverage, which is the interventions that need to be implemented, that the populations who need to receive those interventions, and financing, so who will pay for it. So the global targets for HIV are aligned with the UNAIDS global targets, and they see ending AIDS epidemic by 2030 by implementing fast-track actions, which will lead to 75% reduction in incidence of new HIV cases among general population, and including key population, and 0 new infections among infants. And the same fast-track actions will lead to substantial mortality by 80% of HIV and AIDS-related deaths. And the same 90-90-90 targets are being reinforced again. For viral hepatitis, the first ever global targets are divided into impact targets, which is the reduction of incidence and mortality by 2030, which will lead to elimination of viral hepatitis as a public health issue. And these impact targets are supported by coverage targets for these essential interventions that are needed. So they will set agenda for 2030 with milestones for 2021. So as I already mentioned, the goal of the viral hepatitis strategy is to eliminate it as a public health threat, and it's aligned with all major strategies such as HIV, tuberculosis, and elimination does not mean eradication. We're not talking about eradication as in the case of polio, for example, because the long way of prevalence will still remain for a decade. So the people with chronic infection will still need treatment and care. And this elimination, it has been shown that by modeling analysis that it is feasible if we scale up these 5 interventions. So what means elimination? Elimination is defined by reduction of incidence of new infections by 90% in the next 15 years, and reduction in mortality by 65%. So these are the global. These are the global targets for the interventions. Probably you have seen them already because I'm giving this presentation as not for the first time. And so this the HBV vaccination should be at least 90% coverage, and also prevention of mother-to-child transmission of HBV should be at least 90%, which means either birth dose vaccination or other approaches like antivirals during pregnancy, or testing of pregnant women and selective prevention of transmission. So safe injection coverage targets are setting 90% of use of safety engineered devices. So these are the syringes that prevent needle stick injury and then cannot be reused, because in many parts of the world, even introduction of these single-use syringes doesn't mean that they are really introduced. They are still reused, and most of these needle stick injuries are due to recapping of the needles. The harm reduction here is set as a number of syringes distributed per person who injects drugs per year. And these targets are, of course, they need to be within the package, a comprehensive package of the services for people who inject drugs. And the treatment for HBV and HCV need to be upscaled by 80% at least. And the testing targets is within this target. So 90% need to be tested and diagnosed, and 90% of them will be on treatment. So in the end, it will end up with 80%. So for clarification, this I already mentioned. So there is these strategies provide a framework to implement the guidance and policy that WHO already has been providing for the member states and for the public. And this include guidelines on strategic information that will help to monitor and adjust the response to HIV. So HIV testing guidelines, the latest one were issued last year, and they also guiding countries to expand testing and case finding. Then the HIV prevention, diagnosis, treatment and care services for key population. In terms of hepatitis, there are guidelines for hepatitis C and B. Hepatitis C guidelines were updated, including the most recent antivirals. and the IRV guidelines, which promote now a universal access to, recommend universal access to antiretroviral treatment for all people living with HIV, so-called treat all approach, and also the use of pre-exposure prophylaxis. So these strategies provide the implementation of framework, and the example of this is the evolution of HIV treatment needs, the guidelines. It started in 2003 when the recommended starting therapy was at CD4 to 200. And then in 2013 guidelines, they upscaled for 500, and now since last year, the WHO guidelines strongly recommend to treat all. So this is also the list of the viral hepatitis most recent guidelines. The sexually transmitted infections, the neglected areas already mentioned, still they have a broad impact on the health of the population. They cause fetal and neonatal deaths. They cause cervical cancer in women. They cause infertility, and they also contribute to the risk of HIV transmission, and they compromise the quality of life. So the global strategy on STIs is identifying three priority areas, the gonorrhea, and also including risk of resistance and this multi-resistant gonorrhea. Also syphilis with the focus of elimination of congenital syphilis. And HPV, which can be vaccination against HPV can reduce the incidence of cancer. So the next steps, these global strategies need to be implemented and aligned to the regions and to the countries. We need to build on the regional successes. For example, particularly in the field of elimination of mother-to-child transmission of HIV and syphilis. So we need to prioritize testing to reach populations, settings and locations where disease risk and transmission is the greatest. And we need to work with the community to ensure that all people can access the services they need without fear of discrimination and stigma. And also we need to ensure equitable access to services. So this slide with the reference materials, we can find all the WHO guidelines and also the links to the global strategies. So it's up to you, dear chair, if we should take questions, or we can, yeah, maybe.
Me lembrei. Eventualmente haverá questões ou dúvidas que queiram levantar. Por favor. Eu tenho. Luís, a favor. My question is, those strategies has been approved by the Health Assembly, the WHO Assembly. How strong these recommendations or that approval is to be in terms that countries feel that they must follow? I mean, is there any evaluation of the following process at the country level or not?
On the global level, there will be, all strategies have evaluation and monitoring networks included. So there will be an evaluation of the implementation of the strategy by 2021, and also the midterm evaluation. And then on the national levels, I mean, the WHO cannot say the countries what they need to do and punish them for not doing that, but also the fact of adopting of the strategies means that the countries show their commitment. And also on the national level, the countries need to develop their own policies and their own strategies and set their own targets. Sometimes they could be even more ambitious than the global targets. And so, but there will be a global reporting on the implementation. Also, there will be and also the fact that the strategies set the goal to by 2030, and then the time frame of the strategies is just 6 years. It shows that there will be repeated evaluation and maybe some adaptations on how to improve the global response. I hope I answered your question.
Yes, you've raised other questions, but you answered my question. Just two very quick. The global evaluation will give us information country by country or only by region. And the second one, the monitoring boards or whatever, include civil society representatives?
The monitoring of the health sector response is different for HIV. For HIV, I already have GAPRO indicators, and then also in Europe there is Dublin Declaration, and so this still be because there is already a structure, there is already infrastructure for monitoring, so we know country by country on the on the country's progress, and this will be further also. For viral hepatitis, there is the framework for monitoring and evaluation is under development now. The WHO has published the framework and 10 global indicators, but currently there is no global mechanism for reporting. So probably or hopefully there will be one, or it will be integrated into the Sustainable Development Goals monitoring framework. So we will try to do as much as we can without asking countries to report, to do some additional work on reporting. And the civil society needs to be involved in all steps of the response, including evaluation, of course.
Thank you, Antons, for the comprehensive presentation. Sorry, because I think that we rushed you and made your presentation shorter than it was supposed to be. I hope that we will have available the full presentation because it's useful for us. I wanted to highlight 2 or 3 things. One is that we are at European level, but also at Portuguese level, trying to integrate the responses of HIV, viral hepatitis, TB, and STIs. And we know they are different. There are different specialists treating these diseases, but from the point of view of public health and epidemiology, for us it makes sense, and we would like the support of WHO regarding that. It's a concrete proposal from the Civil Society Forum on HIV/AIDS to the European Commission, but also to the institutions, and we'll see what happens. The second question would be if WHO Europe, with, to tell you the truth, the only institution that puts together the 53 European countries, and we are trying to work at a level of the European continent and Central Asia. It's the mandate of WHO, and it's the only institution that connects all of us in this area. It's WHO Europe, so we need a strong WHO Europe. And we would like to have a Dublin Declaration update that would include the other diseases. So this would mean that we would have only integrated process of monitoring and evaluating the responses to the 4 epidemics, or 5 if you break down the hepatitis. Regarding what you said, and because we have now the responsible for the HIV, TB, and the viral hepatitis in the field, there is a small thing that for us it's very important. We had a program of needle exchange in Portugal for 23 years with different problems, but we still don't have the capacity of monitoring and estimate how many needles are dispensed by injectors, because we don't have the estimation of the number of injectors in Portugal. So this is a key priority that unless WHO says that without this estimation we can still estimate the number of needles distributed by injector, my very simple mathematics, we cannot. I would like to also tell something internal. We have probably 6,000 to 8,000 people in the system with HIV, diagnosed with HIV, that are still not in treatment. And at the current financial situation and current prices, this is a huge challenge for our health system. So I know that some of the WHO also work on affordability, some guidance on how to fight for affordability should also come. Affordability and good treatment, because we cannot accept that the quantity of the people in treatment, it's compromised, leads to compromises in the quality of the treatment. And there is no need for that, but we need to be very clear that we need both things. Universal access and offer, and good quality of treatment. And finally, because I know that this is a huge challenge, we need the support of WHO to recommend the introduction as one of the major breakthroughs in prevention, that is the pre-exposure prophylaxis. We know how difficult it is being and will be, but I think that we cannot delay decisions regarding this. In the key populations, this is an absolute need to control the incidence, to add this tool to the responses. Thanks.
For this one, yeah, sure. Yeah, just.
Jacinta Azevedo, coordenadora da consulta de doenças sexualmente transmissíveis, Centro de Saúde da LAB. How can we know in Portugal what is the evaluation of this plan? What is the national focal point for this plan? It's an innocent question, because in respect to STIs, what do you know in Portugal, or what does know WHO as far in Portugal?
The question was, what do we know?
Yes.
Yeah, unfortunately, at WHO level, regional level, the STIs have been neglected as the same as the global level. Yes.
Just to know.
Yes, I have to confess, and it's true, and that it needs to be changed. Yes, and then there is no much data being analyzed. There's due to
we have the
capacity.
We have the CDC.
Yes, we have.
Data.
Yes.
And the WHO does know what the numbers of the CDC or.
Yeah, we collaborate with ECDC, yes, and we And we need to prevent double reporting, and this is also one of the areas that we are working now with the ECDC on aligning what ECDC is asking for from EU and EEA member states, what kind of information, and so we don't ask the same as we do with HIV surveillance. We have a joint surveillance. We're not asking the same things twice. So, but there is yes, there is still a field of work for us as WHO in this.
Yes, the problem is at national level we have the problem.
Also, yeah,
Okay.
on levels. Maybe to try to respond to intervention of Luis. I agree with all you are saying, and I'm glad that we have very good collaboration with you, and then we can follow up on most of those things, and also in terms of PrEP, as I already mentioned, that PrEP is already included in the guidelines, and probably it will be even more reinforced recommendation. And also we have a staff at the headquarters who is responsible for a medical officer who is working on PrEP, and he's making seminars and trying to involve with the stakeholders to promote and to advocate for the use of PrEP. But there are many different issues, and then more and more countries are working on that. So it probably is a process that can be fast-tracked a little bit. So we should also work on that. I agree. And, so do we have 10 minutes? Okay, that's good. I'll try to go quickly through the European action plans that now are being developed, and hopefully also will be adopted in this year in September. And this means that we can ask, why do we need the regional action plans when we have a global strategy? But the idea is that because the member states all member states were invited to get involved in the development of those action plans, they also feel some ownership of this action plan. And then in the European region, we have the regional committee, when the ministers of health come together once a year and discuss things, and then this will be a region-specific action plan with region-specific targets and actions which are more relevant to the region, and it will be agreed by the governments, hopefully. So in Europe, we are developing only 2 action plans. We don't have a STI action plan, but we are trying to integrate them into those 2 action plans. So first of all, for HIV, we used to have a European action plan, which expired in 2015. And I also have to confess that probably it was not so much known in some places or in some countries, maybe more in Western Europe. But we'll make sure that the new action plans will be on a higher priority. So, then the new global strategy it has been developed and endorsed. That also needs a new regional plan needs to be developed, and. The new action plan is being developed now, and actually we already had all the consultations, so it's being finalized. So we already mentioned, and globally, you see this blue line, the incidence of new HIV cases is going down, but in Europe, the green line. Now, since 2009, it's steadily increasing, and also this yellowish, greenish line, this corresponds to the Eastern Europe. So we can understand that this increase is mostly due to Eastern Europe and Central Asia. But still, even in the Western Europe, the incidence is not decreasing enough in many countries. So we also have the European region is divided in 3 regions. So Western Center is everything which is not the ex-USSR, and the ex-USSR is the eastern part of the region. So, and we can see that the epidemics seem to be different. Like in the west and the center, the blue is, and especially in the west, is the biggest part, which corresponds to infections in men who have sex with men. But in the east, there are almost no MSM in the HIV transmission modes, which also need to be taken critically, because it has been also evaluated that some of MSM and also people who inject drugs are reporting themselves as heterosexual transmission. So the regional action plan adopts the vision of zero new infections and zero HIV-related deaths by 2030, and also sets a global goal aligned with a global strategy. So it has several regional targets by 2020. 3 of them are regarding prevention, so there should be 75% reduction in new infections, including among key populations. And also the reduction of mother-to-child transmission and the reduction of the rate of congenital syphilis due mother-to-child transmission to below 50 per 10,000 live births. So the testing and treatment, the 90-90-90 UNAIDS targets are applicable also for Europe by 2020. And AIDS-related deaths should be reduced below 30,000, contributing towards global AIDS-related deaths reduction. Also, tuberculosis deaths among people living with HIV will be needs to be reduced by 75%, and hepatitis by 10%, which is aligned with the global strategy. Also, zero HIV-related discriminatory laws and policies. So also the European action plan will follow the same structure as I already presented. So in terms of viral hepatitis, the viral hepatitis is actually a much bigger problem in terms of prevalence and mortality than HIV, tuberculosis, or malaria altogether. And it's estimated that there are 13 million living with hepatitis B infection and up to 15 million living with hepatitis C infection. Then the number of deaths is as presented. So that we can say that 1 in every 50 people in Europe lives with hepatitis C, or 1 in 50 lives with chronic hepatitis B in Europe. And in some populations, in some most affected population or populations at risk, this prevalence is much higher, as you know. So the European Action Plan, it sets the goal of elimination of viral hepatitis as a public health threat in the region by 2030 through the reduction of transmission, morbidity, and mortality, and ensuring equitable access to comprehensive prevention and testing, care, and treatment services. So it sets the following targets by 2020, which are mostly higher than the global. So the coverage with the HPV vaccine can be reached at least 95%, and there are many countries, approximately 40%, at least for the EU countries, around half of the countries have already reached this target. And the 90% coverage with the interventions to prevent mother-to-child transmission, which includes either vaccination of newborns or targeted screening and targeted prevention in high risk, or including in high risk women. So 100% of blood donation need to be screened by quality assured methods. And this seems not to be a big problem in Western Europe, but there are still some challenges in Central Asia, for example. Then 50% of injections should be administered with the safety engineered injection devices, and at least 200 sterile injection equipment kits. And all testing and treatment, this seems to be higher than the global that we are hoping to, and we're setting the goal of diagnosing 50% of people living with hepatitis B and C by 2020, and 75 of them should be treated of those who are eligible. And we know hepatitis B, there are eligibility criteria. Hepatitis C, it's recognized that everybody with a chronic hepatitis C infection needs to be treated, but in some countries there are restrictions, and more countries are getting rid of those restrictions. So at some point, the problem of treatment coverage is dependent on the problem of testing coverage. So, and these targets are just the key essential targets. There are a longer list of targets also of setting the national surveillance, of implementing some other prevention measures, including in out of healthcare sectors, implementing the policies in the cosmetology and tattoo facilities and so on. But these are the key targets which are essential for the reaching this ambitious goal of elimination. So these are like summarized the priority actions across 5 of the strategic directions. So the first strategic directions deals with the surveillance and the national planning, and we know that there are very low notification rates in many places, and there is very poor information on the burden of disease, the prevalence and incidence, and then a lot of countries don't have national plans. And then the way forward is to improve surveillance that will lead to better estimates and better recognition of the problem in the country, and this will lead to evidence-based response with sufficient funds provided. So the interventions for impact or second strategic directions is the challenges is that there's still transmission ongoing, not only among key populations, so-called, but also in the healthcare sector. There are still outbreaks of hepatitis C all around Europe, and even hepatitis B. And then, as I already mentioned, the majority are unaware of their infection, and the care and treatment is not always accessible. In most cases, not accessible. So, the way forward is to define these essential service packages, to set national targets, and to make them affordable those who need them. So, the third strategic directions is dealing with finding the populations which are most affected and delivering those services to them, but also with the upscaling the capacity of service providers, including sharing responsibilities involving the community in the response. So the epidemiological evidence will be needed to identify those populations. So because every country has a different profile of the most affected populations, and so we need again a strong surveillance and strategic information to identify where we need to act. So then access the barriers, inequalities, including stigma and discrimination, including laws. And then strengthen the capacity of health sectors and involve the community in the response. So the fourth strategic directions is financing for sustainability, and deals with the financing, which seems a crucial issue for many member states, because the costs of the drugs are unaffordable for the majority of the people. So what needs to be done? So first of all, the response needs to be coordinated with the other health programs, and there are effective price reduction strategies or which can be implemented, and this also building this political commitment based on the investment case. So if the country can produce an investment case and show how much it will save of life of the people and also resources for the country, that it will make easier to advocate and to build the political commitment. And the last strategic directions is dealing with the innovations which are needed in order to increase the response. So we need to still need to develop a HCV vaccine because in some of the population at high risk, elimination might not be so easy without vaccine for HCV due to reinfection and so on. And then the chronic hepatitis B, we still need to better treatment options, and also the better diagnostic, which would allow point of care testing. So this actually is the last slide, and then I just want to tell that we have developed these draft action plans within quite a short time. We had an advisory committee meeting in April, and I'm very grateful also to our colleagues from Portugal who participated in this meeting and provided very important feedback. Both Daniel came and Luis took part in teleconferences. So then we had broad consultations with all member states. We sent the drafts to all the health ministry of every country, received quite a lot of the feedback, and now we are finalizing it to be presented in September to the regional committee. Now we can also open the floor if there's still. Thank you.
Antes de fazer o break para o café, se querem colocar alguma questão ainda. Daniel, desculpa. Estás bocado escondido.
Verdade, obrigado. English is fine. It's just a quick question. I mean, the monitoring issue was already approached, which is very important, of course. But as these targets are indeed very ambitious for a very significant part of the WHO Europe region, WHO's role in assisting some member states in the implementation, and as well as giving tools to help member states structure both information and responses, can be game-changing for many countries. So my question would be, is WHO Europe prepared, and are these tools available to support implementation on the member states?
Yeah, thanks for the crucial question. And yes, I would say there is a lot of work going on, not only in WHO Europe, but also because we are united organization. We have also headquarters, and they have a much more human resources and capacity. But we are all working together, and now the Strategic Information Reference Group met just last month in June, 2 weeks ago. And all the experts were working on setting the agenda, what WHO can do in terms of supporting member states, particularly in strategic information and the modeling. So there will be specific tools produced, or at least some models which already exist recommended, which can be used for both monitoring and modeling the burden of disease, but also for building the investment case and kind of estimating the costs of the response and the possibilities to optimize the response using the resources already available and so on. So yes, it's very important, and we are working on it.
Thank you, Antons.